And welcome to this training session where I'm going to be introducing the concept of vocational rehabilitation. So this is aimed at healthcare professionals in our stroke network and across all disciplines and grades. So my name's Kate Hammond. I'm an OT by background. I'm currently working on the Vocational Rehabilitation Catalyst project as the specialist VOC rehab trainee. So this is funded by Squire, which is Stroke Quality Improvement for Rehabilitation Fund, but it's also in conjunction with the Walton Centre and the Cheshire and Mersey Rehab Network and the Cheshire and Mersey Integrated Stroke Delivery Network. So I'll just introduce the aims of the session. So I'd like to understand a brief background into how these training sessions have come about, to define vocational rehabilitation, to outline the key components, consider why we work in a general sense, look at how the role of OT and how that links with the profession in VR, thinking about an MDT approach to VR, the benefits and challenges. So the project itself has been funded by Squire, and that was developed to support kind of 20 national stroke networks. I said about the integrated stroke delivery networks, in looking at kind of implementing quality improvement for bringing it in line with national guidance and service models. So we identified as part of this project that there are training gaps across the network in vocational rehabilitation, and that's at all different levels. So we've actually developed some curriculums that can target the foundation knowledge, intermediate and specialist level knowledge. So this at the moment is the foundation level. The intermediate curriculum is being targeted to our community of practice, which we've developed through this project as well, and that's mostly community therapists in stroke network, occupational therapists that are working with working age strokes doing vocational rehab. And the specialist curriculum is aimed at myself in terms of me being the specialist VR trainee and upskilling me. So let's have a little think about vocational rehabilitation then. What's it all about? What are your perceptions of VR? Kind of have a little think about how confident you are in your understanding before the session. It's going to be a short session, about 25 minutes, so just be introducing some of the bits. Have a little think, and then I'm going to share with you what we came up with when this session went live earlier in this week. So here we have mostly people saying about returning to work, getting people back to work, education with the employer, looking at phased return, adaptations that can be made to return. So yeah, you can see those there. That's just on a word cloud completed. So if you look at some definitions of VR then, it's like anything, there's always more than one definition. It's very hard to choose one that we like, but we're basically looking at enabling individuals with a range of different impairments, whether that's physical, cognitive, emotional, to prepare for, obtain, maintain or regain employment. And it's kind of, just in another sense, it's looking at education, training or alternative occupation, and looking at to entering that, returning to or remaining in that sort of employment. And we consider that vocation isn't just paid work, it can be voluntary work or perhaps something like being a family carer. It's an active process that is relies on motivation and effort of the individual, and supported by the workplace, healthcare professionals and third-party organisations. And then finally, just whatever helps someone with a health problem to stay at, return to and remain in work. So if we look at kind of the aims and objectives of VR intervention overall, and this is across a scale, and in the next module I'll be going through kind of a practice model of three different stages of vocational rehab intervention. But in a general sense, we look at returning to work and education, and remaining in that as well. So it might be looking at getting people back into work and how we might have to adapt that, but it's also making that sustainable and a successful return. Finding work in the first place, getting access to education. Retraining and redirection is a big one. That's quite a complex level of VR intervention, which is normally done at specialist level. Supported exit from work, big one of those being maybe ill health retirement, or somebody might decide that they no longer wish to work, and it's looking at how they leave in the best place possible. And then something that we can all do across kind of the stroke journey is signposting to support, things like government initiatives, charity organisations. So if we have a little think about what the key components of VR would be, I think one of the biggest things is that it's multi-professional and multi-agency approach. So whilst we recognise that OT generally is the lead profession, we need to work together as an MDT, just like any other aspect of rehabilitation. If we're thinking about health-related difficulties impacting on function, would be that approach to rehab. This is function in work. So it's just another goal. We can pull in the expertise of all professionals in the MDT. So we can kind of approach those multifaceted ways of recovery post-stroke. And I think from a multi-agency approach, we consider it needs to be NHS, then other organisations as well, such as the government or charities, and where they have funding to kind of be best placed. We need to consider that it's ageless. So we need to think about the fact that we don't just assume just because somebody's a certain age they no longer work, or are they too old or too young. Nowadays we're working with people who are having strokes, they're getting younger, and there's more people having strokes that are working age, but also it's people are working for longer. We're generally, our population are living longer, so therefore we're working for longer. Age of retirement is gradually increasing. So we've got kind of two aspects of that. Thinking about promoting the impact of work on health and well-being, and how kind of we've already thought about, or we're going to be thinking about why we work, and it's promoting that importance of it on health and well-being. There's quite a lot of statistics to show that actually the longer you're off work unwell or off on sick leave, the less likely you are able to make a successful return. So after 6 months of absence, there's only a 50% chance of being able to make a successful return to work. And as the time increases, the less likely those chances are. Kind of said it before that it's really important to kind of set that as a goal to reflect as an essential part of recovery after stroke. And so, goals should be an MDT approach, and it's thinking about how we can target that, and it should be an integral part of our stroke rehab journey, really, from word go to kind of all the way through until they're discharged and being managed in the community. Sorry if my little video is over the top of that. There it should say high on the agenda in current climate. It's a bit of a hot topic at the moment. It's not necessarily, VR itself isn't necessarily a new phenomena. There's just a lot more awareness out there at the minute about how important it is of making accommodations for the workforce with disabilities, and how healthcare professionals are best placed to support that. And it's basically promoting us to put us on the map to show that we've got a really good role in supporting that for the wider economy. So just have a little think now, why do we work? So I guess, what are our main reasons for working? Though, think about those motivating factors that you might have personally, or what have you come across professionally in your role of people who are trying to get back to work after they've had a stroke. And I'll share with you some of the thoughts that we had when we did the session. So money being kind of the main one that people were putting up there, but I think for me that's why I started working in the first place. So I had money to do things at the weekend when I was younger, or save to go travelling, you know, those sorts of things. And then as you get older, that you know, you have more to pay for in life, don't we? Cost of living, mortgage, children, you know. So that's kind of like an overarching main reason. But what was really nice is people came up with so many other reasons why we actually go to work. Just a couple up there that were most the ones that are in colour, the ones that were said more often. So identity, routine, social connections, sense of purpose. You know, it being good for our mental health. It's rewarding. We get enjoyment from it. Self-worth, satisfaction. So there's lots. I could tell it was a group of therapists and healthcare professionals that were completing that, because they really had an idea of considering lots of other aspects of why we go to work. So I think if we can see such a broad sense there, you can really understand why it's so important for us to target this with our patients, with regards to setting goals after they've had a stroke. It's really, really important parts of their life. So if we just have a look at some research that the Royal College of OT did about why we work. And for those who wish to work, you know, this is just echoing what we've just said about income, financial stability, social contact and interaction, support, networks. You're spending time with like-minded individuals, aren't you? And it's kind of gathering that. A lot of time we've got some of our really good friends that are at work. It's having that identity and that role, that status of where we fit into our world, I guess. Habit, routine and structure, which was mentioned, and I think when we've got that routine and structure, it's easier to make healthy habits and stick to those healthy habits when we're in. And I think that's really important for patients as well. Often after stroke, they are needing to kind of get into new routines and new ways of doing things, and work can provide that, obviously, if it's appropriate. Again, sorry, my little bubble's covering the last of that word, but satisfaction of contributing to society. I know that was mentioned when we did this training live, that it's around having that passion and then that giving back to those people that, you know, giving that satisfaction. So if we consider occupational therapists, then obviously that's my background, and if we kind of think about how we are a good profession for kind of specialising in VR, it tends to be the lead profession. Obviously recognise that other professions do specialise in VR as well, or lead on education. You know, physiotherapy and psychologists are also other services across the country as well. But go on to more about the MDT approach on the next slide. But if we think about key OT skills, so problem solving and thinking about those complex and unforeseen challenges. It's quite a big one for OT. Breaking down activities and analysing them in the general sense, but also in the work sense. Making sure tasks are suitable for individuals and how we would perhaps look at compensating for those. And that's normally through grading and adapting. So it's looking at implementing modifications or adapted techniques, just to help support kind of improving work performance. Learning's a big thing. Obviously, we're looking at new ways of doing things, compensatory techniques, relearning skills that perhaps they had pre-stroke that maybe have been lost due to cognitive problems, or relearning how to use complete tasks with the visual problem or upper limb problem, balance issues, those sorts of things. Education, obviously, on condition management, but also educating family caregivers, and then also in the work sense, it's looking at maybe other healthcare professionals, agencies, and employers as well, and colleagues as well. Sometimes it can be around the understanding of colleagues for an individual going back to work, and that stigma sometimes is what puts people off. We're holistic in our approach to the person, and we consider kind of the environment. You'll be familiar with OTs going and looking at home environments for discharge, or adapting home environments for safety at home. And it's just the same with job environments, work environments. looking at changes for accessibility and safety and how we might have to modify things. Occupation, obviously, kind of does what it says on the tin, OTs, and see occupation as something not just work, but it's kind of what makes you you and the roles that make you a person. Critical thinking, to looking at different perspectives. And then finally, functional training. So that's kind of what underpins our profession. We kind of look at a range of sources to ascertain how it's going to impact on daily life and function, and looking at those practical hands-on techniques for training, and the same in like daily work tasks and environments. So it might be that rather than doing looking at like you kind of bread and butter looking at kitchen and washing and dressing, it might be more those tasks that are needed for in the work environment and how we would get somebody trained and functioning in that. But then if we consider an MDT approach, so obviously it's really important. So I just wanted to kind of touch on how we can work as an MDT to kind of target those vocational goals, and just wanted to think about where we overlap. Obviously, there's a lot of the skills that I touched on in the OT that I'm sure you can all recognise that you also might do in your professions across the MDT. And we all take that holistic approach, don't we? Especially in stroke rehabilitation, we need to be considerate of everybody else's professions so that we can look at that whole picture of how a stroke might have affected somebody. You know, it's physical, cognitive, psychological, the social aspects, communication, vision. You know, that's not an exhaustive list, obviously. And kind of through that, looking at them holistically, we have to complete comprehensive assessment, and that's where working together as a team is going to support that. Looking at multiple factors that might impact or affect work performance after stroke. Using our clinical reasoning, so we're gathering information from a range of sources, using those kind of comprehensive assessments, looking at the goals we've set, looking at progress made to date, and how we would tailor those and make those decisions to support rehab process, but also vocational rehab process. We're client-centred, so we tailor interventions to individuals, and it's no different with job-specific needs and goals, really, and we need to be mindful of that at all times. Obviously, goal setting, there's lots of evidence to suggest that that should be an MDT approach, but also with an active participation from the patient, understanding that if they are motivated and they have expectations of you know, realistic expectations, and they've been managed by a multidisciplinary team, we're more likely to have successful outcomes in the rehab side of things. We want to promote health and well-being. It might be when we promote secondary prevention, medicine management, condition management, emotional support, you know, increasing physical health, those sorts of improvements. And it's the same with work. I guess we need to promote how work is healthy for our well-being. Shared decision making as well, so that's where we overlap and complement each other. It's that interdisciplinary working, isn't it, where we kind of do a little bit of each, you know, within our boundaries, but putting our heads together and making sure our best practice for the patients. And like we said there with the goal setting, it's considering what the patient's preferences are and their values, and then use our kind of expertise in our condition, in stroke as a condition, in our job, to help kind of come together to make those decisions. So if we have a little think about benefits of VR, I think what probably is the key thing to recognise, if I bring them all up, I'll bring this one up first and then I'll bring the others up. There's evidence out there to suggest that with vocational rehabilitation intervention, there's improved job retention and success in returning to work, in the broader sense of things. But also, if I bring these up, these are all of basically the same things that we spoke about with why we work. So obviously, if we can promote that use of VR to support return to work, we're also going to have a look at all these holistic kind of positive things that happen. And we've spoken about healthy routines and social integration financial security, identity, role, personality. It's just a huge, and we show that if there's evidence to suggest that if we've got that early intervention and that support, going to empower somebody to manage their condition long term, hopefully try and prevent long-term disability. And then I think probably the economic side of things, there's a big national drive at the moment around getting people back to work. Long-term sickness costs the economy, and I think if we can support patients that can go back to work and that would be happy back in work, then we can kind of, it's like a win-win situation there. So if we have a little think about challenges as well, just to kind of finish off, I guess. I probably should have done it the other way around, as saying this in the other thing. Should have finished on a positive, but it's thinking about how we look ahead as well. So I guess funding and commissioning is the kind of two of the same, but there's limited access to sufficient funding for VR services, whether that's actual service delivery or training. The neurological networks are a little bit more advanced, or a bit more advanced in that the reason why we're doing this project in conjunction is because of the developed vocational specialist VR in the Cheshire and Mersey Rehab Network. And that's been, established for at least the last 10 years. So we're trying to kind of use their model to look at what's working well to try and reflect that for future commissioning in our services. It's a bit of a postcode lottery as well across the country, so there's some very well established services, there's some not so much, and it kind of depends on commissioning priorities as well. This is a big aspect of our project that we're doing. We recognise that obviously there's lack of a consistent provision of training, or it's needed to be funded through the trust, and I think there's a lot of expectation that it's learning on the job. There's lack of access to subject matter experts without, within the network that we can access and share knowledge, and it's patchy provision, and I think it's really important to consider how we can make that more joint up. So that's why there's a large focus on education as part of this project. It's very hard to know what's available sometimes, and services change so often dependent on funding streams, current government agenda. It's very hard to keep up. So trying to promote what's out there is for people who, especially if they don't have the NHS service and they kind of maybe fall through a net in terms of support with returning to work, who do we signpost them to if we're not always sure what's available? Just considering kind of how being flexible, and there's so many diverse needs that we need to meet these days. It's very important, but it's challenging when we're pressured services, with vacancies, short staffing. That's kind of particularly tricky. We need a bit more of a collaborative approach between stakeholders, healthcare providers, employers, policymakers. We don't all kind of work on the same joint up systems, so it can be quite tricky to each talk to each other. And then, sorry, my bubble's covering up the end, but that should say need to ensure resource for an MDT approach to VR intervention. So it's, a lot of services, and I know when we've part of the project been surveying the community services, a lot of them don't have full access to the core professions, let alone be able to be resourced for a full VR service. So it's kind of looking at levelling up and then adding on those specialist services on top. So I just wanted you to have a little think about keywords to kind of summarise what you've learned, or maybe just jot a few bits down so you can use it as part of kind of your CPD. Sometimes good to do it on in the moment, so you hasn't gone out your mind. And then I'll share with you what was discussed this week. So we've got, that MDT approach. I think hopefully people recognising that everybody's got a bit of a role to play in work and introducing VR, and the role of the MDT. Education, knowledge, the resources, thinking about voluntary work as well as paid and those caring professions. So yeah, so you can see up there. There's just some of the references that I've used for the information and facts on here. Obviously some further reading as well if you wish to have a look at those. The slides will be available on the shared workspace, and I'll also email them round. So if you do have any questions, you can always drop me an email, whether it's about what was discussed in this session, or if you've got a particular patient on your mind that you aren't sure about, you can drop us an email, and myself and Ray, who also works on the project with me, can look at how we can help you. Thank you very much for attending.